Welcome back. Today I will go over innervation of the lower extremities. This is another long lecture, so bear with me. You can watch it on multiple times, or you just can watch it one time. But it's very important to build on the fundamentals for the lower extremity innervation and pain. So the lower limb basically divided into gluteal region, thigh, leg, and foot. As you see here, this is the pelvis, and this is the femur, and this is the small bone here is the fibula, and the bigger bone is the tibia. Then, of course, you have the ankle and all these details. This is just a brief overview. So here, important landmarks will be the ACEs, the anterior superior iliac spine, and PCES, the posterior superior iliac spine, and of course, the iliac crest. And you see here the orientation of the hip joint, and from here down, you have the lower extremity. Now, here you have the blood supply for the lower extremity. As you see, it's coming from the common iliac artery, which give the two major branches, the internal iliac and the external iliac. As you notice, the internal iliac go to the pelvis, and the external iliac go to the lower extremity as the femoral artery. And the femoral artery give few branches here that are important to know. When you look for nerves, whether you are trying to diagnose something or do a block or peripheral nerve stimulator, oftentimes you will see the blood vessels, they are your friend. So you find the vessel and then you find the nerve close to it. So for example, here you have the deep iliac circumflex artery. It's an important landmark when you do the fascia iliaca block. The lateral femoral circumflex artery, it's important when we look for vastus lateralis nerve, and etc. Of course, the femoral artery, very important here. And when you go down, of course, the dorsalis pedis here. If you go look at the back, of course, you have the popliteal here, and when you go up here, also the superior gluteal artery is very important. We will see a lot of examples now. Veins also the same. So, for example, here the greater saphenous vein run with the saphenous nerve. The small saphenous vein here at the back run with the sural nerve, and etc. We'll see a lot of examples. So it's important to familiarize yourself with the blood supply. Now, when we talk about lower extremity, the lumbosacral plexus is the main innervation. So it's two plexus. We call them lumbosacral or lumbar plexus and sacral plexus. The lumbar plexus originate from L1 to L4 with a small contribution from T12, as we will see in a few minutes. And then the sacral plexus, a small contribution from L4, then all the way down with the sacral. So here on the right side of the screen, you will see the lumbar plexus. Again, small contribution from T12, then L1 to L4, and you see the branches, which we'll go over, and then you will see the sacral plexus here, which is again from L4 mainly to S4. So if we look at the lumbar plexus, it gives you the iliohypogastric, ilioinguinal, genitofemoral, lateral femorocutaneous, femoral nerve obturator, lumbosacral. It is very important to know the root, especially when you are considering more truncal block or when you're considering DRG stimulator or spinal cord stimulator. On the other hand, here you have the sacral plexus, which give you the superior and inferior gluteal nerves, the sciatic nerve with its two main branches, posterior femorocutaneous nerve, and perforated cutaneous, and of course the pudendal nerve. So when we look at these nerves going down the thigh, so of course the anterior you have the femoral nerve as the main branch, the main nerve. So soon it bifurcate, give you the muscular branches, and then after that it give you the saphenous, which is this is the saphenous here, and the saphenous continue to the leg, and here you have the lateral femoral cutaneous. If you look at the back, the main nerve is the sciatic. It doesn't give major branches on the thigh. It starts to bifurcate about the popliteal fossa here and give you the common peroneal and tibial. And the tibial continue as sural and tibial. We will go over all these details in the next few lectures. So a couple of concepts here I want you to keep in mind when you think about lumbar and sacral plexus. Here, if you see the lumbar plexus, the nerves coming from the nerve spinal roots, and it goes with the abdominal wall, and it goes inside. So it's running with the abdominal wall muscles, and it goes inside. And if you peek here and look at the sacral nerve, see how they are in the pelvis. They are behind the sacrum. The second concept, when you look at the muscles that cover the lumbar plexus. So here you have the longissimus muscle, then you have the iliocostalis muscle, both form the erector spinae, then you have the QL muscle, quadratus lumborum. Then if you start to look from inside, you really don't see the plexus until you remove the psoas major, because the plexus goes through the psoas major. This is important when we talk about the lumbar plexus block in a few minutes. Now, again, when you look at the sacral plexus, it's inside the pelvis, it's behind the sacrum. If you look at it from the back, you have the piriformis muscle that's covering the greater sciatic notch, and underneath that, the sciatic nerve is coming. So if you really want to block the sacral plexus, you have to go behind the piriformis muscle in that fossa. Now, a common example here is the lumbar plexus, just to keep things within the context. This is not meant to be detailed explanation how you perform it, but just to understand the relevant anatomy. So around L4, you place your ultrasound, and then from the midline you keep moving lateral until you see what we call the shamrock picture here, the shamrock picture. So the shamrock picture is nothing but the erector spinae here, the quadratus lumborum, and the psoas muscle. And the TP, the transverse process of L4, is basically the stem of the shamrock. So as you see, the lumbar plexus is really within the psoas major muscle. It's posterior medial, just anterior to the transverse process. So back in the days, this used to be a landmark technique block where you just draw a line 4 centimeters from the midline, and you go with your stimulator and look for the contraction. Nowadays, with the ultrasound, it's easier. You still need to do, and you look for contraction oftentimes because again the plexus is not that visible. It's within the psoas muscle. Now, when you talk about sacral plexus, it's not a common performing block because basically you can block the sciatic nerve, transgluteal, and that will cover the entire leg. But if you look in the literature, there are multiple approaches reported. There is the lateral approach, the short axis method, the long axis method, the suprasacral parallel shift approach, which is coming from the lumbar plexus above, and the anterior approach, which is, I don't want to go deep there, but the whole concept, you really have to go deep there and insert the medication toward the pelvic cavity. This is the other approach. This is the basically the lateral approach. Okay, more relevant and more important now for pain management. We have to understand dermatomes, myotomes, and osteotomes. This is a paper I published a few years ago, basically for the total knee replacement procedures, and show you different innervation and different dermatomes. But basically, the things that you have to remember and kind of memorize to help you with this. So over the inguinal ligament here, this is L1. Then lateral side of the thigh, it's L2. Lower medial side of the thigh, L3. Medial side of the great toe, L4. Then medial side of digit 2, just here in the middle, that's L5. Then little toe, it's S1. Then back of the thigh, most of the back of the thigh is S2. Skin over the gluteal fold, S3. And here we see more dermatomes, but think about nerves more than spinal nerve root. So, for example, here you have the iliohypogastric nerve, and then clunial nerve here, genitofemoral, ilioinguinal, posterior femorocutaneous, this area here, lateral femorocutaneous, neuralgia parasitica. We'll have a lecture on that, obturator nerve, saphenous, etc. So this is extremely important image when you consider pain management. And here you have the myotome. It's also very important to differentiate between myotome, osteotome, and dermatome. So for example, the obturator nerve here really supply the adductor muscles. The quad muscles and the sartorius muscle by the femoral nerve, the hamstring by the sciatic nerve. And when you go down, you see that the common peroneal nerve, which is a branch from the sciatic nerve, responsible for the dorsiflexor muscles, plantar flexor from the tibia. Now, when we look at the osteotome, for example, if you take the femur bone here, as you notice, most of the innervation of the femur bone from the femoral nerve, but you still have a small area from the obturator nerve. Look at the hip there, mainly we will go over the hip in the next few slides more. Here another important example, like let's say the ankle. If you look at the ankle, very small area, the medial malleolus, gets supplied by the saphenous nerve, which is a branch of the femoral nerve. However, the remaining part, the majority of the ankle from the sciatic. If you look at the foot in general, mainly from the sciatic. This is important. So imagine you have bilateral foot surgery and you are putting a nerve catheter. You are limited by the amount of local anesthetic you are using. So it's probably you can put bilateral popliteal sciatic and escape that small femoral contribution. So you have most of your local anesthetic going to the major innervation. So you get the idea. So it's important to keep this in mind. Now let's go and look at the muscles of the thigh. And before we dive deep on the thigh, it's important to familiarize yourself with these important muscles. So here you have the psoas, major and minor, iliacus, very important muscle, as we have seen with the fascia iliaca, which we'll show you in a minute. Here, gluteus maximus. Underneath that, you have the piriformis, very important muscle. And then when we start to go down here, so that's the tensor fascia lata, all the way up here. And then when you look here, the tensor fascia lata give you the iliotibial band. So the continuation of that muscle is the IT band. Then here you have the sartorius, extremely important muscle when we talk about different nerves block. And then here you have the rectus femoris, and here you have the vastus lateralis. So that's the sartorius. So if I remove the sartorius, as you see in the remaining pictures, underneath that, from medial to lateral, we start with the adductor magnus. So this is adductor magnus, adductor longus, and adductor brevis. So these three muscles called the adductor muscles. And often we remember them by Alabama. So adductor brevis, followed by adductor longus, followed by adductor magnus, Alabama. Now, if you see here, you have the pectineus, which is also important landmark when we start talking about obturator nerve. And iliopsoas muscle, of course, which is nothing but a combination of two muscles, very important when we talk about femoral nerve. Now, what we are doing here, so you still have the sartorius and the rectus femoris. So if I remove here, I remove the sartorius, and I remove the rectus femoris. Underneath that, we see three muscles. We see the vastus intermedius here, then the vastus lateralis, then here the vastus medialis. So these three muscles with the rectus femoris form what we call the quadriceps muscles. Here we start to look at some vessels. So here a bigger magnified picture here. So you see the femoral nerve, the femoral artery, and the femoral vein. So if you, it's VAN, V-A-N, starting from medial to lateral. And here, just more zoomed in, we see the femoral nerve start to branch and give the muscular branches and give you the saphenous nerve. These muscular branches, as you see, 1, 2, 3, 1 is vastus medialis, 2 vastus intermedialis, 3 vastus lateralis, and 4 rectus femoris. They are very important, especially when we start talking about knee innervation. And of course, this is the deep femoral artery and the femoral artery and vein. And here is the great saphenous vein before it gives you the femoral artery. The deep femoral artery give you an important branch which called the lateral circumflex femoral artery. This is very important, especially when we talk about blocking the vastus lateralis. Why? Because the vastus lateralis, as you see here, it runs with the descending branch of the lateral circumflex femoral artery. So here, just a different angle, you see internal muscle, which is at that level. So here there is no sartorius. I remove the sartorius. Underneath that, you have the iliacus muscle. So you see the femoral nerve going above the iliacus muscle here. And then the psoas muscle is that small medial part. Here it's a different angle. Again, this is the lateral femoral cutaneous nerve. Again, there is no sartorius in this picture, and femoral nerve. So why this is important? Because there is two applicable blocks here. And again, the purpose of this lecture is not to dive deep on the blocks. I will have more lectures for that. But let's look at the fascia iliaca plane block. So it's in the fascial plane above the iliacus muscle. Usually, more recently, people do it above the inguinal ligament. So it's called supra-inguinal fascia iliaca. And then it's below, of course, the fascia iliaca. The deep circumflex iliac artery, as I mentioned, is a very important landmark. And I said is or are because sometimes they are too. It's superficial to the fascia iliaca. So this block, it potentially block the femoral nerve, the lateral femoral cutaneous nerve, and less commonly the obturator nerve with a single injection. But it's a high volume block. So you really need to put a lot of volume to block all these three branches. And I will show you in the next slide why is that important. So that means when you put a catheter, and let's say you are giving bolus every 2 hours, 10 ml or whatever, right? You have less chance to block the obturator. And I will explain to you in the next slide. Now, back in the days, there is something called 3-in-1 block. It's old historical name. No one uses it now, but just if you've seen it in the literature. So basically, they go and infiltrate the femoral nerve sheath with the local anesthetic. And the thought was if you use a larger amount of anesthetic with caudal pressure to encourage the anesthetic to drift cranial, that potentially can involve the lateral femoral cutaneous and the obturator nerve. However, as you will see, it's very hard to believe that's true. So it turns out basically it's the femoral nerve. And this is why no one using this term anymore. So now to explain the concept of the fascia iliaca. So here is the inguinal ligament, right? Iliacus muscle. So you see here the femoral lateral femoral cutaneous. So we are going here, and as I mentioned, you are going below the fascia iliaca, above the iliacus muscle, right? And you inject the medication. So the medication will spread here, right? The medication will spread here, and it makes sense it will cover the femoral and lateral femoral cutaneous. However, if you pay attention, where is the obturator now? So the obturator, you have to, again, remove the psoas major to see the obturator there. So that's why you need a larger volume even to reach the obturator, and that's why it's not always blocking the obturator, especially if you're going to depend on a catheter. But I believe if you put 40 ml, and there are studies showing that you can reach the obturator, of course. Now, let's look at the back of the thigh. So as you notice, I'm going over muscles, nerves, but trying to make it more entertaining by showing you the clinical application with nerve blocks and all. And I will start to talk about diseases as well. So here you have the gluteus maximus, you have the iliotibial band, and then you have the hamstring muscle, which is nothing but a group of three muscles: biceps femoris, semitendinosus, and semimembranosus. And here the posterior femoral cutaneous nerve. Now here I remove the gluteus maximus muscle. So this is more magnified image. So here you have the sciatic nerve, the biggest, longest nerve in the body, right? And then you have the inferior gluteal nerve, and this is the superior gluteal nerve. Here you have the pudendal nerve. I have a lecture on the pudendal nerve. Then here you have a posterior femorocutaneous nerve. I also have a lecture on the posterior femorocutaneous nerve. Now, if you look here at the hamstring muscle, right? So I'm going to remove the hamstring muscle for you. So we will see the the sciatic nerve. As you notice, there is no major branches of the sciatic nerve until it starts to bifurcate to common and pro and tibia. So here is the adductor magnus. Here is multiple small branches of the sciatic, the common peroneal or fibular, some references, lateral, and the tibial medial. Now, let's go at axial cross sections. This is extremely important when we talk about adductor canal block and different femoral branches block. So I'm going to go with you from above and down and show you these cuts, how change and how it's applicable when we do blocks. So here, this is very high up in the thigh. This is the rectus femoris, and then sartorius, and here you have the adductor muscles. The adductor muscles here, which make the medial compartment, we'll look at that in a few slides. The adductor longus, brevis, magnus. Remember Alabama, right? And then here you have the lateral compartment muscle, which is the vastus lateralis, right? Then vastus intermedialis and vastus medialis. And here you have the iliotibial band. Here you have a small part of the pectineus. Here at the back you have the hamstring or the posterior compartment. You have the biceps femoris and the semimembranosus and semitendinosus. Lateral femorocutaneous nerve is here. Anterior cutaneous nerve is here. Muscular branches of femoral nerve. Saphenous nerve. Sciatic nerve. Posterior femorocutaneous nerve. Now, going slightly lower, as you notice, the femoral rectus femoris and sartorius. So watch the sartorius. Now it starts to move more medial, right? And then the other thing here, pay attention to the adductor muscles, how they're going to change. So now, again, rectus femoris, sartorius. This is adductor longus and magnus, previous. Where is previous? No previous at this point. And then notice how the vastus medialis start to move more medial. Tibial band, no major changes here. Biceps femoris start to give you the two heads, but there is no major orientation change in the posterior compartment happening. Innervation, the lateral femorocutaneous give you multiple branches at this level. Anterior cutaneous still there, muscular branches underneath the rectus femoris. And then you have the obturator start to branch anterior and posterior branches in relation to adductor longus. Adductor longus, we will see that also in the obturator nerve lecture. And then here the saphenous nerve. However, we are not yet in the adductor canal. We will see that. Then here you have the sciatic nerve and posterior femorocutaneous nerve. Moving more down here, now we are at the level of the adductor canal. Why? So see the rectus femoris and sartorius more medial here. See the adductor longus and magnus become smaller. It's almost like one muscle here. You still have the muscular branches. Pay attention to this vastus medialis, how it become big and more medial. That's a saphenous nerve in the adductor canal now, right? And that's the obturator nerve, at the terminal end of the branches. So you hardly see them here. So here, probably just at the end of the femoral triangle, just starting to see the adductor canal. It's hard to be accurate in this cut. I will show you more pictures. This is the sciatic, this is posterior femorocutaneous, lateral femorocutaneous, multiple branches at this level. Now, going further down, closer to the popliteal fossa. So look at the rectus femoris. Where is the sartorius? It's really medial now. Now, what's this big gigantic muscle? That's the vastus medialis muscle. See how it become bigger. Adductor magnus only. There is no previous, there is no longus. And then here you have a small muscle. Sciatic start to bifurcate as this level, as you see, posterior femoris. And here, now, if you remember, so pay attention to three muscles. Look at the sartorius, 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 right? Look at the rectus femoris, rectus femoris, rectus femoris, no major changes. Now look at the vastus medialis, vastus medialis, vastus medialis, vastus medialis, vastus medialis. Notice there is no major change in the vessel orientation, which changing really the muscles. And this is important when I'm going to talk to you now about how we determine the femoral triangle versus the adductor canal. So the thigh divided into three regions: distal iliopectineal fossa, distal femoral triangle, or femoral triangle and adductor canal. So the femoral triangle formed by the inguinal ligament here, and then the medial border is the medial margin of the adductor longus, and then the lateral margin is the medial margin of the sartorius, and then the floor is formed medially by the pectineus and adductor longus muscle in the medial compartment of the thigh, and laterally by the iliopsoas muscle descending from the abdomen. The apex points inferiorly and is continuous with a facial canal, which is the adductor canal. Now, the region between the apex of the iliopectineal fossa and the apex of the femoral triangle define the distal femoral triangle. So this here is the iliopectineal fossa. The black one is the femoral triangle. From the end, from here, the femoral triangle, to the adductor hiatus, this part here called the adductor canal. And the length of the adductor canal varies between people. References say anywhere between 8 centimeter to 15 centimeter. Here, the apex of the femoral triangle is the most distal aspect of the femoral triangle and the cephag margin of the beginning of the true adductor canal. It is defined as the location where the medial border of the sartorius muscle cross the medial border of the adductor longus. So the sartorius muscle is removed when it crosses the medial border of the adductor longus. Here we have the end of that femoral triangle and the beginning of the adductor canal. The distal border of the adductor canal is the adductor hiatus right there, where it's also important where the femoral artery descends through the adductor hiatus to enter the posterior compartment of the leg, posterior fossa, and is renamed as a popliteal artery. Now, if you put your ultrasound here, and you are in the femoral triangle, so you see the vessels medial to the sartorius. If you put it here, you start to see the vessels under the sartorius. If you put it here, you start the vessels going to the lateral end of the sartorius. I will go in more depth on when we talk about the adductor canal block. Now, adductor canal, also known as Hunter canal, it's formed by the vasto-adductor membrane anteromedially. So that's the vastus medialis, remember that. And then the fascia of vastus medialis anterolaterally, and the fascia of adductor longus or magnus posterior. So that's fascia. But if you look at muscles, so The laterally you have the vastus medialis, medially you have the adductor longus, and superiorly you have the sartorius muscle. Now, how to differentiate between the femoral triangle and adductor canal? This is also important when we do these blocks. So the sartorius muscle form the lateral margin of the femoral triangle, while it's the anterior medial or superior for the adductor canal. Adductor longus, it's in the floor when it comes to femoral triangle, while its posterior medial border, right, for the adductor. Vastus medialis, it's not visible, it should not be visible in the femoral triangle. Here it gives you the anterior lateral border. Femoral artery and vein, as I showed you here, they are medial to the sartorius here underneath and little bit lateral. The content here, this is why it becomes relevant when we do blocks. So you have the femoral nerve, and it start to branch off here. While if you go here, you only have the saphenous nerve. And again, I showed you this ultrasound when we place it. So let's go below the knee. Below the knee, here you have the tibia, tibialis anterior, medial head of gastrocnemius, and soleus, which is an important muscle when we talk about tibial nerve, flexor digitorum longus, and extensor digitorum. So extensor muscles, lateral, flexor more medial and posterior, and extensor hallucis longus. Now here we added some nerves. So you have the greater saphenous vein, you have the saphenous nerve running next to it, and you have the lateral sural cutaneous nerve and the superficial peroneal or femoral nerve. Here, looking from the side, you have lateral head of the gastrocnemius, the soleus muscle, the tibialis anterior, extensor digitorum, as I said, extensor lateral muscles, flexor longus. And then here added some nerves. You have the common peroneal nerve. It's very famous how it take a turn around the head of the fibula. And then lateral sural cutaneous. The sural is very interesting nerve. Watch my lecture on the sural nerve. Then here you have the superficial peroneal nerve. Now looking from the back, you have the lateral head of the gastrocnemius, the medial head, and then the soleus muscle, calcaneal tendon, and here the greater saphenous vein, the popliteal artery and vein. This is the small saphenous vein. So the greater saphenous vein, you see the saphenous and its medial crural branches. You see the common peroneal here, posterior femoral cutaneous end at this level, lateral sural cutaneous nerve, sural communicating branch, and the medial sural cutaneous nerve run with the small saphenous vein, and the sural nerve below that. Saphenous nerve run with the great saphenous vein, important landmark. Now, looking at axial cut here, so notice that how deep at this level the tibial nerve here, the saphenous, the sural nerve. Here you have the deep peroneal nerve, and you see the orientation of the tibia, the fibula, the muscles. Now, when we go all the way down, this change the muscle. There are more tendons here. So you see the sural nerve here. You see the superficial peroneal nerve here. This is the deep peroneal nerve here. Posterior tibial nerve here. And you see the saphenous nerve here. Now, important also to know the compartment and the fascial plane of the leg. So in the thigh, there are three compartments. The medial, which is medial compartment, which is mainly adductor compartment. Anterior, it's an extensor, and posterior is a flexor. So most muscle in the medial compartment act mainly on the hip. Large muscle, hamstring in the posterior compartment, act on the hip extension and knee flexion. Muscle in the anterior compartment, which is the quadriceps femoris, quadriceps group, predominantly extend the knee. So here again, the compartment, you see the fascia lata here. So the anterior compartment contain mainly the quadriceps muscles, which is the quadriceps femoris, rectus, the rectus femoris, the vastus lateralis, vastus medialis, and vastus intermedialis, innervated by the femoral nerve. And then you have the medial compartment. It has 6 muscles, mainly the adductor muscles, brevis, magnus, and longus, and mainly innervated by the obturator nerve. The posterior compartment, mainly the hamstring muscles, and mainly innervated by the sciatic nerve. When we go here on the leg, again you have 3 compartments. You see, notice the what was called the fascia lata is fascia cruris, or crural fascia. So here you have also 3 compartments: anterior, medial, and posterior. And you see the different muscles in each compartment. Now, speaking of fascia, so we all know the fascia lata. So the fascia lata is nothing but a continuation of the scropas fascia in the abdomen and the collis fascia in the in the scrotum. And now let's shift gear and talk about some important joint innervation. Again, very relevant for pain management. So the hip has the superior portion of the anterior capsule, and the labrum were found to be the area of dense nociceptive. So here most of the sensation. This is why most of the osteoarthritis pain present in the groin, because most of the nociceptive receptor in the anterior capsule. While in the other hand, the mechanoreceptor, they are also anterior and posterior. So when we talk about innervation of the anterior capsule, it innervates by the femoral nerve, which is these yellow branches, and the obturator nerve, which is these orange branches, and a small accessory obturator nerve. When we look at the posterior capsule, it innervates by the superior and inferior gluteal nerve, and branch of the quadratus femoris, and branch from the sciatic nerve. The femoral, obturator, and superior gluteal nerve supply articular branches to most of the nociceptive region. This is why if you end up blocking or ablating the femoral and obturator branches, you very much controlled most of the pain, not all of the pain. Now here, let's look back at the posterior, which is more complicated. So here you have a branch of the superior gluteal nerve. So the superior gluteal nerve really supply all this area. So this is really applicable if you're trying to treat posterior hip pain, right? And then here you have a small branch of the inferior gluteal, then a branches of the sciatic, and branches of the nerve to quadratus femoris, and very small branches of cutaneous branches. So the main one is really the superior gluteal, and then you have small area here from nerve to quadratus femoris. If we look at the front, this is femoral and this is obturator. So these are the two major innervation. Now let's talk about the knee. So the knee is more complicated, more innervation. So now we are looking at the anterior capsule. So if we just look straight here, right? So you have nerve 2 vastus lateralis, and then you have less important nerve 2 vastus intermedialis and vastus medialis. If we look at the lateral view here, this is the lateral view. So in the lateral view, you see there is a superior lateral genicular nerve. You see common fibular nerve, and you see inferior lateral genicular nerve with a branch of nerve 2 vastus intermedialis. Now, if you look at the medial view here, mainly the superior medial genicular nerve and the infrapatellar branch of the saphenous nerve. Here, more details, more zoomed in the medial, that's the infrapatellar, and here the superior medial genicular nerve, and here again the nerve 2 vastus medialis. Now, here looking at the posterior capsule, in the posterior capsule, you have branches for the anterior and the posterior branches of the common peroneal. And here you have the superior branch of the tibial nerve, inferior branch of the tibial nerve, and you have the posterior division from the obturator nerve. So putting them together, as you see, most of the posterior capsule supplied by branches of the common peroneal and some contribution of the obturator and the superior and inferior branches of tibial. So here, number 1 is superior lateral genicular nerve. Here, number 2 is the inferior medial genicular nerve. And here, number 3 is the recurrent fibular nerve. So putting things together, in summary, that's mainly the anterior capsules innervated by femoral nerve. So the femoral nerve give you the nerve 2 vastus medialis, nerve 2 vastus lateralis, nerve 2 vastus intermedialis, and then the superior medial genicular nerve and infrapatellar branch, as you see all these added here. Then the sciatic give you the superior lateral genicular nerve, the common fibular nerve, inferior lateral genicular nerve, recurrent fibular nerve, inferior medial genicular nerve. So notice in this specific reference, they put the superior medial genicular nerve as a branch of the femoral nerve, only the superior medial, which makes sense, right? And then in the posterior capsule, you have the obturator, which give you the posterior division, and you have the sciatic, contribute mostly sciatic, common fibular, and tibia. So here, again, it's a summary. You can save this slide. But what I want to show you, when we do genicular nerve block and when we do genicular nerve ablation, so this is the superior lateral cutaneous nerve, and we do the superior medial genicular, superior lateral, superior medial, and we do the inferior medial genicular. So it's very obvious that this will not give you complete pain relief. This will not give you complete block because you still have branches from other nerves. However, it's an easy and straightforward procedure, so it's always worth starting with that, especially talk about chronic pain. I will have a lecture on that. So just remember all these innervation. Now, here is another picture. I want to show you specifically the infrapatellar. Now, these are the nerves So these are the nerves. In this specific reference, they put them all as branches of the sciatic nerve, right? However, remember the other anatomical studies show you this is as the femoral, which make more sense. However, if we, again, when we think about genicular nerve block and radiofrequency ablation, we are missing major innervation, right? Nerve to vastus medialis, lateralis, intermedialis. So this, again, more relevant to think about how much pain relief you will have, right? Now, another important nerve is the infrapatellar nerve, which is nothing but a branch of the saphenous nerve. And it's a lateral underneath the patella. It's pure sensory, but it's very important because it's a commonly injured nerve during surgery because of retractors, etc. So notice how the course of this nerve, and notice how it pierces through the sartorius muscle. And I will go over the blocking of this nerve when I talk about the saphenous nerve lecture. Now, this is my approach just to simplify things. So this is mainly, as you see here, for pain post total knee arthroplasty. So this is why I put an artificial knee. So this is a common problem. I think it's very reasonable to start with genicular nerve. But however, as I showed you in the previous slides, what's the innervation of the genicular nerve, what we expect from that. But my approach, let's say you did the genicular nerve, it's not enough to divide the knee into 3/3. So middle third, medial third, middle third, outer third. So if the pain is mainly in the medial aspect, then I will go with the saphenous nerve. If it's in the midline, like anterior, I will go with nerve to vastus medialis. If it is lateral, then I will go with vastus lateralis. If it's more localized here, then probably it's an infrapatellar nerve, and I will go after the infrapatellar nerve. Again, we'll go in more details on this. This is just to, stimulate your appetite to learn more. And finally, we'll wrap up and talk about the ankle joint innervation. So the ankle joint, this is, looking from above. So this is the Achilles tendon. This is the talus, right? And here, if you look, this is so this is the medial malleolus, and this is the lateral malleolus. So behind the lateral malleolus, you have the saphenous nerve running with the saphenous vein, the short saphenous vein. Behind the medial malleolus, you have the tibial nerve. You cannot miss that nerve. It runs with the posterior tibial artery. This is why I spend time showing you the blood vessels, because it's very important landmark. Then here, in front of the medial malleolus, you get the saphenous nerve, which run with the long saphenous vein. And then here, in front of the lateral malleolus, very superficial, you get the superficial fibular nerve. Almost midline, and behind that is the deep fibular or the deep peroneal nerve, which run with the dorsalis pedis artery. So vessels are your friend when you find these nerves. Okay, so these are a lot of references. Thank you for watching, and make sure you watch the other lectures in the lower extremity. Thank you.